the recording. The webinar is being recorded. There are closed captions available. I would ask that everybody please remain muted throughout the webinar, and please hold any questions until afterwards. I'm going to be keeping an eye on the chat, so please feel free to drop any questions that you have in the chat feature, but otherwise we will answer any questions at the end of the presentation. And today, Key Finding 3 and the recommendations stemming from that are going to be presented by two of my colleagues, Adrienne Langlois and Craig Ismaili. They are both on the institutional rights team at DRNJ. So I will let them get started. But again, thank you very much, everybody, for being here. And we will address any questions at the end. Thank you.
Yes, thank you for being here. Today, we're going to be talking about Key Finding 3 in the report, which discusses how people with IDD are not afforded their constitutionally protected right to self-determination regarding where they live, nor are they afforded meaningful opportunities to engage in federally mandated and assured person-centered practices. As a result, people with IDD are forced into nursing homes and are thus denied interactions with non-disabled people. As we say in the report, a choice of one, a nursing home, is not a choice. And today in the report, we're going to be the presentation. We're going to be going through 4 different topics. One is individuals with IDD have a fundamental right to self-determination. The next one is going to be how person-centered practices the framework exists under federal law. Next, we'll be discussing person-centered practices in nursing homes, especially nursing homes in New Jersey. And then finally, we'll also be discussing housing barriers to access to the right to live in New Jersey, the right to choose where you want to live in New Jersey. So first, let's start off with what is the right to self-determination. And Article 1, Paragraph 1 of the New Jersey Constitution sets out that all residents of New Jersey are entitled to the right of self-determination. As it says, all persons are by nature free and independent, and have certain natural and inalienable rights, among which are those of enjoying and defending life and liberty, and of pursuing and obtaining safety and happiness. To that effect, the New Jersey legislature has routinely affirmed this right when addressing the rights of individuals with intellectual and developmental disabilities. New Jersey state law requires that services which are offered to the developmentally disabled shall be provided in a manner which respects the dignity, individuality, and constitutional, civil, and legal rights of each developmentally disabled person. And services should be offered provided, quote, in a setting and manner which is least restrictive of each person's personal liberty. This right is further explored for individuals with intellectual and developmental disabilities in the landmark In Re MR case. This decision in the New Jersey Supreme Court held that even where a person with an IDD is subject to general guardianship, the guardian must demonstrate by clear and convincing evidence that the individual subject to guardianship is not capable of making the decision about where they can live. Even when the court rules that the individual with an IDD is found not to have capacity to make a decision around where they want to live, the guardian must satisfy the, quote, substitute judgment test, which means that they must choose the action not that a reasonable person would, but what choice the person with the IDD would have made if able to choose, taking into account the decision the person with the IDD would have made prior to being incapacitated. And so what our report found was that residents of nursing facilities with IDDs are not granted the right to self-determination. More than half of the individuals with IDD that we spoke with during the outreach stage of our report across 70 different nursing homes said that they did not choose to live in a nursing home and that they preferred to live in another setting or wanted to return to live in their home receiving HCBS services. So that's why we said throughout the report, a choice of one, a nursing home, is not an informed choice under the law. Residents with IDDs are sometimes not asked by their guardian and care managers about their preferred living arrangement. Take, for example, the case of LC. It's a story that we discussed in the report. LC is a 68-year-old woman who was discharged from the hospital to a nursing home for rehabilitative services. 11 years later, LC remained in a nursing home, despite her repeated expressed desire to move back to the community. Disability Rights New Jersey successfully assisted Elsie in moving to a group home in the community in her desired location in the state. What we found throughout the process of this report is that the failure to incorporate these principles into the PASSAR process, which was discussed in our last webinar, undermines the rights for people with IDD, even those coming from HCBS settings, when they are at risk of nursing home admission. Ultimately, the constitutional right to self-determination with respect to expressing a preference about where one lives is not a reality for most people facing nursing home admission, and certainly not for people with IDD. And it goes further than just the right to determine where the resident wishes to live. Residents should have the right to self-determination in the care they receive as well, which brings us to the other part of key finding 3, which is that New Jersey does not do enough to uphold nursing home residents' right to person-centered planning. So first, we have to ask, what is person-centered planning? And person-centered planning is a set of approaches designed to assist someone to plan their own life and supports. While person-centered planning has been present in federal laws governing long-term care since at least the 1987 Nursing Home Reform Act, the legal right to person-centered planning was most recently updated by CMS in 2014 through the HCBS settings rule, and then again in 2016 through revised nursing home regulations. It's worth noting that, as found by the New Jersey Supreme Court in In Re MR, and reiterated again by these updated federal regulations, even individuals with IDD who have a guardian are entitled to the right to person-centered planning. Court-appointed guardians can only exercise rights given by the court, and the resident retains the right to make decisions outside of the guardian's authority. Guardians must consider residents' wishes and preferences, and residents must be given every opportunity to participate in the care planning process. So next, we're going to talk about the 2014 HCBS person-centered planning rule. This federal rule outlines a Medicaid recipient's rights to person-centered planning. The HCBS rule applies to all people receiving HCBS services in New Jersey. A person with IDD receiving services from DDD in the community is on one of 2 waivers, either the supports program or the community care program. Under both programs, the individual has a supports coordinator, an employee of an entity contracted with DDD. The supports coordinator is responsible for coordinating necessary services and supports under the waiver. This includes developing a person-centered plan of care. A person's representative should have a participatory role only, quote, as needed and defined by the individual leading the process, absent state law to the contrary. There is no state law to the contrary in New Jersey, and so the person leading the process is the individual receiving the services. These rules set out that the service recipient must direct the process to the maximum extent possible, and that the state Medicaid agency must offer informed choices regarding settings, including non-disability specific settings and options for private residential settings, and they must record alternate options considered. The written service plan must also be understandable and include written informed consent of the individual receiving the services, and it must be reviewed at least every 12 months or whenever the individual circumstances change significantly, or whenever the individual requests any revision of the care plan. Now, Adrian, I believe, is going to take us to the next part of the presentation.
Thanks, Craig, and apologies, everyone. My computer camera appears to have decided to cut out just before I started speaking. So appreciate you bearing with me. So thanks to Craig, we know that Medicaid recipients, including people with IDD in the community, are entitled to person-centered planning. So what about nursing home residents? As of 2016, federal law requires nursing homes to engage in person-centered planning for all residents. Within 7 days of admission, a nursing home must develop a comprehensive person-centered plan of care for a new resident. This person-centered plan must include, under the federal regulations, the services that are to be furnished to attain or maintain the resident's highest practicable physical, mental, and psychosocial well-being, as well as measurable objectives and timeframes to meet those needs. It must also include any services that are otherwise required, but which the resident has exercised their right to refuse treatment, which is another right under the federal laws. Additionally, it must include specialized services that the nursing home must provide as a result of PASSAR recommendations. Remember those from webinar 3. And this part is really important in terms of the person-centered natureness of the plan. In consultation with the resident and residents representatives, the nursing home's person-centered plan must include the resident's goal for admissions and desired outcomes, the resident's preference and potential for future discharge, as well as documentation of any referrals made as a result of those residents' preferences, for instance, for options counseling, and the resident's discharge plans. This plan must be developed by an interdisciplinary team, which specifically is supposed to include the resident and/or their representative. So, who is responsible for the person-centered plan in the nursing home? Federal law specifies that states' person-centered planning is the responsibility of the nursing home. State law specifies that discharge planning, which is a key element of the person-centered plan required under federal law, is the responsibility of the nursing home social worker. However, New Jersey's high maximum resident to social worker ratio, 120 residents to 1, this is the maximum ratio, and we definitely see social workers at that max, sometimes above it. This poses a barrier to effective person-centered planning and discharge planning for nursing home residents, especially those with IDD. We often find that social workers don't necessarily have a lot of knowledge of services and supports for people with IDD in nursing homes. So with this context, let's move on to our specific recommendations for finding 3. First, DRNJ believes that New Jersey should review all person-centered practices throughout the long-term services and supports continuum, with the goal of ensuring compliance with federal law and the constitutional right to self-determination, as described above. New Jersey should also review and revise all service plans and planning processes to comply with federal law. So one example that we'd like to see them review goes back to the federal home and community-based services rule that Craig described. The rule says that a person-centered written service plan can't just list off covered Medicaid services. The plan has to go into more depth and explore the person's likes, dislikes, and goals. Second, New Jersey needs to change the current practice of shifting people with IDD who enter a nursing home from community waiver programs to managed long-term supports and services, or MLTSS. Some of you may know that currently, if an individual receiving a DDD services enters a nursing home, they retain their support coordinator for up to 180 days. This number recently increased from 90 days thanks to approval from the Centers for Medicare and Medicaid Services, also known as CMS. After 180 days in the nursing home, the individual's care switches from DDD waiver services to managed long-term supports and services provided by a managed care organization. While the recent increase in the amount of time that a DDD service recipient can retain their waiver services, including their support coordinator, is good, the state should ask CMS to change the time limit on waiver services while in the nursing home to 360 from 180, giving them almost a full year. This is all towards the end of having DDD clients retain their support coordinator who has expertise in person-centered planning and community-based supports while they are in a nursing home. Third, DRNJ recommends that the state require and provide specialized training and nursing home diversion to support coordinators and MCO care managers. Specifically, support coordinators should have specialized training in nursing home diversion and transition. DRNJ would like to see DDD dedicates staff to work with support coordinators and individuals with IDD residing in nursing homes in order to help them develop discharge and transition plans. We at DRNJ don't just have recommendations for DDD. The Division of Medical Assistance and Health Services, also known as DMAS, also has work to do. When a person on a DDD waiver enters a nursing home and transitions from waiver services to MLTSS, they lose a support coordinator, but gain an MCO care manager. MCO care managers aren't responsible for discharge or person-centered planning, but they could be more effective advocates for their clients with some changes to the system. In order to prevent longer-term nursing home residents, particularly people with IDD, from being warehoused, DRNJ recommends that DMAS significantly reduce the maximum caseloads of nursing home MCO care managers. It's currently set at an extremely high 240 clients to each MCO care manager, so even double that of nursing home social workers. Additionally, DMAS should provide or require that MCOs provide specialized training on nursing home transition to MCO case managers. I've met a number of MCO case managers who are really helpful and great advocates for their clients, but this is all about making sure that everyone has the tools that they need in order to help transition people to the setting they want to be in. Finally, for both support coordinators and MCO care managers, New Jersey should provide training on how to identify and refer residents with IDD, and as well as how to educate residents in their family on Section Q. Very briefly, Section Q is a part of the minimum data set, or MDS, in which nursing home residents are to be asked whether they are interested in returning to the community. If the resident and/or their representative answers yes, referrals must be made and documented in order to ensure that the resident receives options counseling on their opportunities to return to the community. We have a final finding 3 recommendation. DRNJ would like to see the state add an innovative consumer education and training waiver service to MLTSS supports and the community care program. So we would like to see this based on Wisconsin's example. Wisconsin received approval for this waiver service in 2015, and the service allows the state to use its funding to educate consumers on its rights. So it would be a service that they could bill for. Proactively educating people with IDD on their rights before they enter a nursing home provides another safeguard against unnecessary institutionalization, helps build self-advocacy skills, and is about as person-centered as you can get, in my opinion.
So with that said, just a reminder that this is the last of our 4 webinars on our Person First report on individuals with intellectual and developmental disabilities in New Jersey. The recordings and slides for the first 3 webinars are available on our website at disabilityrightsnj.org, where you can scan the QR code on the screen. If you go to our website and click on the pop-up about our report, you'll be able to see the presentations on the report and the report as a whole with all the other key findings. Or you can go to the link in the chat, which we're about to post. And I think these slides and this recording will also be up on the website shortly. So with that, we'll open it up to questions.
Thanks, Craig. I just wanted to get to some of the questions in the chat first, and then certainly if anybody else has any other additional questions, we're happy to answer them as best we can. Linda had made a comment about private duty nursing as adding that to, I'm assuming, this CCP program. And that is something that we are taking a look at, an analysis of any kind of implications of that. So I know that there are lots of conversations about that being a possibility, and we're certainly trying to do our due diligence around that as well. And then there's a question, it says, can DDD make case managers available to those in nursing homes instead of social workers? So my assumption is that this is about the supports for people in nursing homes. And so, as Adrian had said, if somebody is on CCP for 180 days, they maintain, they're still on that waiver program. But after that point, they will then switch to MLTSS. But the nursing home, the social worker is still involved in the process. It kind of doesn't overstep them. And then the last one is, I believe, in reference to LC, about why that individual, why it took so long for them to be kind of discharged from a nursing home. I can see if Adrian might be able, she might be able to speak to that a little bit better about that individual. And then I will just keep an eye on the chat for any other questions. But Adrian, are you able to speak to LC and just kind of some of the barriers to discharge briefly?
Certainly, yes. And I appreciate the question. And I think I often encounter this when I'm describing my work to people. They say, like, how can someone get stuck in a nursing home for 10 years, 20 years, even 3 years, 4 years? And so I think a key thing to note here is that this client, LC, had lived independently in the community, had received other varying points DDD and DDS services, and she went, so she's currently 68 now, but so 11 years prior, when she was 57, she had an infection in her toe and it had to be amputated. And it was a situation in which the doctor who did the surgery and was making recommendations for a recovery felt very strongly that she needed to go into long-term care after rehab. And as a result, there wasn't a lot of discharge planning done. It doesn't appear, I wasn't able to review records from her previous nursing home before I met her, but doesn't appear that she was ever asked any of the questions that she was supposed to be asked related to, her desire to return to the community. And we actually encountered her during our report outreach and investigation. And it seems at the time that she had finally been connected with DDD, but we were able to provide a lot of support in both in terms of helping herself advocate for herself and what she wanted, and also throughout the process in making sure that she received the accommodations that she needed to make an appropriate decision and not feel pressured. So I certainly wish that we had found her sooner, but I would say we met her, I believe, in July 2021, and she was out in the community on June 1st. I know she wanted to be out sooner. I wanted her to be out sooner, but I'm glad that she was able to achieve that.
Thank you, Adrian. And I know, so there's also an earlier question from Mary about the availability of services in the community. And that's something obviously at DRNJ that we is such a big part of the work that we do, particularly the work that we do on the institutional rights team. We have a community inclusion team as well at DRNJ. And so part of our, the work that we do is about trying to advocate for additional community placements. And I think that the situation with LC does kind of highlight the fact that it's not always necessarily an issue of services not being available in the community, that there can be breakdowns in the system in various different ways. And like Adrian had indicated, that there were questions that really weren't being asked of LC. There are things, kind of breakdowns in that system that led to her being in a nursing facility for certainly a lot longer than she wanted to. And some really wonderful advocacy by Adrian allowed her to be moved fairly quickly and be in that community. But certainly a lack of community placements, appropriate placements, that kind of thing is certainly a big issue that we care very deeply about. So thank you. Thank you for that, Adrian. And then I see there's another question. I think, Adrian, you had spoken to this earlier at a previous webinar about the active treatment plan and specialized services. I didn't know if you wanted to just add anything else to that.
Certainly. So Mary's question is, what can you speak to whether an active treatment plan, which is what the services in a DC are called, is the same as specialized services. Specialized services as robust as outlined in Appendix J. I can confidently say that in New Jersey, under New Jersey state law's definition of specialized services, they are not, because as noted within the report in prior webinars, New Jersey's state plan defines specialized services incorrectly, defines it essentially as services that can't be provided in a nursing home, defines for people who have mental health conditions, which they call SMI. They define it as services that can only be provided in an active inpatient psych system. And the Center for Medicare and Medicaid Studies is very, very clear that this is not what specialized services are supposed to be. They are supposed to be able to meet the needs of the individual where they are. It's supposed to be equivalent to services that they could receive under a community-based waiver. So basically any services that could be crafted to meet that person's individual needs. And I think it's also important to go back to sort of the definitions of what of person-centered planning, both in the HCBS rule and in the nursing home, and the focus there is not just like, is it, you can't just be Medicaid services. You can't just list off and say like, oh, this person needs assistance with their ADLs, so they would essentially need a personal care attendant. It has to go more towards, okay, maybe this person needs help making decisions. This person needs help calming down because they can easily become angry or frightened. Supposed to go more into that, be less clinical. So there's a lot of work that New Jersey has to do. So, and that is one big thing that we really wanted to see changed because of this report. So while I'm certainly not as familiar with Appendix J, we know that the specialized services in New Jersey are extremely deficient and in their definition, and do in fact violate federal law, which was part of the reason why we wanted to write this report and push for those changes so that specialized services can be robust, so that people can, if they want to, if they make that choice to, live safely and happily in the community and exercise that right to self-determination.
Thank you very much for that, Adrian. And so it looks like there is another question about the individuals that it really couldn't be accounted for in the report. So we, as we've stated in the report, we had a list of about 567 individuals that we were working with, but a review of the minimum data set, the MDS, indicated that there were thousands of people in nursing homes with intellectual and developmental disabilities. And from the first quarter in 2020 to the second quarter in 2020, that number dropped significantly. So we don't have any analysis, or it's information that we're not sure exactly what happened. And it's obviously concerning because that drop was so significant and happened during really that first very deadly phase of COVID. So part of the recommendations and part of the ask that we have within this report is about asking for there to be a review of that data and some kind of determination to be made about it. Because again, of the number of concerning things that we found related to the work that we did in this report, that's certainly one of them that we would like the state to take a look at, try to do an analysis of. And so it looks like there's been a few comments about community services. So I would characterize some of these questions about community services are really about being appropriate community services. And so I think when we're speaking about options in the community, home and community-based services, all of these kinds of things, what we're really speaking about is there being appropriate services. So for example, with the case with LC, this individual was able to be transitioned not necessarily very easily. There were some obstacles that Adrian had to overcome in it, but was able to be transitioned to a community placement. But that's not always easy for a lot of individuals that are in nursing homes and other institutional settings. And so really, it's not just about building up community placements, home and community-based services. It's also about building up appropriate services. And, that's why I think part of this is about having appropriate data, appropriate information about people in order to build up those services on the community side to make sure that they are appropriate. And that does go for individuals with more complex medical needs, with dual diagnoses, different things like that. It's really about those robust services in the community that are providing appropriate placements for individuals.
And investing housing too, right? I know we talked in the report about the Medicaid Healthy Homes initiative. We talked about state budgeting in 2024 for disability accessible homes and low-income homes. That I know is another component of this, that having those available in the community can also it's another part of this, that it's investing in housing in the community also affects ability to transition people out of nursing homes.
And then Linda, we will certainly, continue what we can to figure out what we can and continue to ask the state questions about that drop in the populations in nursing homes during COVID. And I know, Linda, you had mentioned about going off mute. I don't know if anybody else has any other questions. I'm not seeing anything else. But I really just behalf on everybody at DRNJ, I want to thank everybody for their participation, for their willingness to come to these webinars. This report has been something that we've been working on for quite a long time and have put a lot of work and effort into. And as it seems like, I'm sure that a lot of the people here know, this is really just the beginning. It's really a continuation of the work that Disability Rights New Jersey has been doing for a significant period of time, but it's really also a starting point for us. So we will, continue to advocate for all of the recommendations in the report, all of the kind of questions that we have stemming from it. But I really do appreciate everybody. Just one final call for any questions, if anybody has them. Linda, your hand's up. Yep.
Could I speak? Can I just speak for a sec?
Of course. Yeah.
Okay. I just wanted to say to everybody, you did a lot of work and this has done a lot of good. It's really validated what parent advocates have been fighting for over a decade, which is the fact that things don't exist in the community that can meet the needs of everybody. And I think that, this really drove that home. But I wanted to point out something subtle. On page 53, it's sort of a bullet point you might just roll right over, everyone. But it's talking about the community care program. And actually, it's the key to a successful resolution of everything, in my opinion. It says the CCP provides an array of services, including group homes, to individuals who meet an institutional ICF IDD level of care. And legitimately, what's been wrong for decades is the fact that the ICF level of care has not been replicated on the waiver. And I don't think there's anyone on this call who could say that that's not true. It literally was never replicated. And one of the things that's needed really that they have, in addition to a mindset that is sort of, getting people better, never giving up on people, giving people choices. The other thing is that they have on-site or very close access to a lot of specialists like respiratory care specialists. So people with ventilators can live at a DC. Right now in New Jersey, they can live at a DC, or they can live at a hospital, or they can live at a nursing home. And that's such a layup to be able to fix in a community setting. So for example, in the ICF level of care gives you access to things. Now, just yesterday, Senator Steve Sweeney, huge project at Rowan University, where there's going to be 24 campus-based apartments for people with IDD. So it's a higher density setting. And they're going to have access to psychological, behavioral, education, and everything services right on that campus. And campus-based settings is something that must now be allowed because it's being allowed by Steve Sweeney and some other enclaves in New Jersey. That affords sort of a hybrid between the community and an ICF level of care. And whether we have to carve out a new waiver because the other one won't stretch far enough, I hope that everybody within the sound of my voice will consider doing that, because it really is a solution. It allows access to care, it allows being in a community, and it also allows for hitting that ICF level of care. If we had done that, we would not be having this conversation today. So with that, I would like to say, if anyone wants to ask me anything, you can. If not, I would just want to say what a terrific job you did on this very, very difficult report to pull together. So thank you.
Thank you very much for that, Linda. I appreciate that greatly. I know that that this is obviously very complicated work for all of us, and it is something that requires advocacy from a number of different people, and certainly the advocacy of families involved in these systems as well is extremely important and very valued. And for sure, we really just want to make sure that individuals' rights are being protected, that they are able to live in the least restrictive settings possible. And again, that these programs, these services, housing in the community is something that is going to be something that doesn't put people at a risk of institutionalization. So thank you very much for those words.
I would also just add too, because I think there's sort of a key thing here, and to note is that there's no law certainly against building ICFs or more institutional like settings. What it comes down to ultimately is whether or not, because the federal government can't stop that, the state government can't stop that. They could, obviously they have opportunities for licensing and things like that. But Medicaid does determine whether or not they will pay for services in ICFs. And I can't say, and I cannot speak to whether this particular format of the campus style, if that is something that Medicaid would pay for. But there is I think it's worth noting that the distinction ultimately in terms of what's available and what can be provided does go back to Medicaid.
Well, thank you very much, everybody. Again, I really appreciate everybody's participation, willingness to have these conversations. And I think obviously since everybody is here, it's very clear that that everybody else also shares a passion for this work, a passion for trying to do the advocacy that that we're talking about. So we appreciate all of you as well. Certainly could not do it without all of us trying to make these changes. So again, this is the final webinar related to the report. You can certainly check out the previous webinars on our website. We have additional information on there, and you can feel free to reach out to us if you do have any other additional questions, anything else. But thank you very much, everybody.